today. My name is Erin Tinnen with the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar will be introducing the trauma-informed practice scales for domestic violence programs. Our trainers today will be Lisa Goodman from Boston College, Dr. Chris Sullivan from Michigan State University, Dr. Eleanor Lyon from the National Center on Domestic Violence, Trauma, and Mental Health, and Dr. Carol Warshaw, Director of the National Center on Domestic Violence, Trauma, and Mental Health. Before we get started, I'll go over some of the technical details of the WebEx software that we will be using for today's webinar. Many of these details are explained on the Using this WebEx System tab on the upper left-hand side of your screen. Please be aware that your screen might look a little different depending on whether or not you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have any questions regarding the training content. You may contact Jennifer Curley, also with the center, if you have any questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You will see a lot of options, but for this session, you will want to select all participants if you would like to respond to a question from the trainer or contact me anytime during the session. You should click on Jennifer Curley to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in the program that you're calling in from, and then press Enter. Wonderful. Thank you all so much for kicking that off. You can continue to share your programs with us if you like. While folks can get a lot out of the chat feature, there are times when it moves really quick and can feel distracting. If this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word media viewer the same way you might if you want to hide the chat box. At the end of the webinar, you will be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes sound cuts out due to internet connection, so feel free to call in if that becomes a problem for you. If you're experiencing technical difficulties and are unable to contact Jennifer Curley, you may call WebEx Tech Support to resolve any additional issues. That phone number, which we will also post in the chat box, is 1-866-229-3239. Again, thank you so much for joining us today, and I will now turn the training over to Lisa.
Thank you, Jen, and thank you everyone for participating in this webinar. We're really hoping that the tip scales will be useful to you in your work. So I wanted to provide a brief overview of what this webinar will look like. The first thing I'm going to do is speak very briefly about what trauma-informed approach is, though we are assuming that everyone on this call has basic knowledge of what this means. And then I will go on to describe also very briefly why we developed the scales. And then I want to turn to spending some real time on how we developed and validated the scales. And this part will be a little bit researchy, but we thought it was important for you to understand how these scales were created in order to determine whether they are going to be right for your program. Excuse me. So after that, I'm going to turn it over to Chris, who will talk in some detail about how you might use these scales in various ways in your program. And then I'll be turning it over to Eleanor and Carol to talk about how this might play out in your program and in the field. So I just need to figure out how to, there we go. So turning to what is a trauma-informed approach. As you all know, the idea of trauma-informed practice was first developed in the early 90s in response to evolving knowledge of the high prevalence and impact of trauma. And then since then, its principles have, this is review, have spread from mental health and substance abuse services to schools and prisons and shelters and hospitals and, of course, domestic violence programs. So it's beyond the scope of this webinar to talk about it in much detail, but we will be, its principles will become evident, at least how we think about them when we get to the scales itself. But for now, this slide basically summarizes its philosophical underpinnings, which is the idea of a shift from thinking about what is wrong with the people who walk through our doors to thinking about what happened to them. And this shift frames clients or survivors' actions and experiences as understandable responses to recent or earlier or historical trauma, and then demands that programs structure their practices around this kind of framing. So turning specifically to domestic violence programs, some DV programs have always strived for a trauma-informed approach to their work, even if they didn't call it that, and I think for others this is relatively new. I want to point out that in 2001, what is now the National Center on Domestic Violence, Trauma, and Mental Health was the first to sort of explicitly bridge the gap between domestic violence work and trauma-informed principles. And they, and the two main people are on this call, have made available a whole range of materials and technical assistance opportunities, and other groups have done so as well. But what we have heard over and over again from practitioners is that what is still missing are practical tools to help them understand their work and identify gaps and sort of track growth over time. So after having heard this for a number of years, a group of us decided to take on this task by developing a tool that could meet this need. And before I describe it, I'll just mention some of the people who were most directly involved. In addition to Chris Sullivan and myself, at Boston College, we also had Josh Wilson, Jennifer Fauci, and Craig DiGiovanni, doctoral students who were part of this project. Also centrally involved were Josie Serrata and Julia Parilla at the National Latina Network for Healthy Families and Communities, and Carol Warshaw and Eleanor Lyon on this call from the National Center on DV, Trauma, and Mental Health. We also had support of 15 experts from around the country, as well as scores of advocates and survivors involved with this project, and you'll hear about how they collaborated in a few minutes. So our goal was to create a set of scales that could be used easily by community programs to identify their areas of strength and weakness, to improve their practices, and to demonstrate to funders and other key stakeholders that they are incorporating trauma-informed principles into their work. We also set ourselves a few key challenges. One, we wanted to focus on really concrete practices rather than just broad principles. We wanted to emphasize survivors' perspectives on how trauma-informed a program is. There are, as many of you know, several assessment tools already available for staff to use to assess organizational capacity, but what staff think may not drill down to how survivors experience a program. So, and then finally, we wanted to tackle all domains of trauma-informed practice, even if some of them are really hard to make explicit in the form of concrete practices. And that was our main challenge, is how to concretize some of the ideas that are buzzing around about trauma-informed practice. And note that because we focused on survivor experience and concrete practices, the tool we developed does not focus on organizational culture or organizational policies. That is, I think that there are some measures available that can do that. But this one really focuses on the daily practices that are visible to survivors. So the whole process of developing the TIP scales took about a year and a half and involved collaboration with multiple domestic violence programs and hundreds of survivors. This process can be broken down into 3 steps. First, developing scale items. Then next, administering the draft measure that we developed to programs, survivors in programs across the country, and then using those results to refine the measure and ensure that it meets standards for validity and reliability. So I'm going to just describe each of those steps in some detail next. To develop the items for the TIP scale, we took a bunch of steps to ensure that the items would be comprehensive, relevant, and clear. First, we did a thorough review of research on TIP, especially when I say TIP, I'm referring to trauma-informed practice. So we did a review of research on TIP, especially in the domestic violence context. Second, we conducted 15 interviews with research and practice-based experts on TIP in the DV context, including consultation with a number of the culturally specific DV resource centers around the country. We also did a series of focus groups with survivors and with advocates, and these were in English and Spanish. Based on these sources, we generated an initial draft composed of a huge list of items. We then pilot tested this draft with a smaller group of survivors to make sure that all items were easy to respond to. And only after all of that did we arrive at the final draft, and this was just a draft still, of 62 items, which we had translated and back-translated from English into Spanish. So the next step was to administer the draft scale to as many survivors as possible to be able to collect data for testing reliability and validity. We sent it to 15 residential and community-based programs with which we have working relationships. These represented a whole range in terms of services offered, setting, location, participant demographics. And the program staff at each one of these places helped us to recruit participants for the survey, and all participants received $20 Target gift cards. The draft survey also contained several other measures that would be critical for testing construct validity and reliability, and you can see them here. In total, we collected 370 valid surveys from survivors. The last step was to take the survey data to further cut down the measure and to evaluate its reliability and validity. So we did a factor analysis first to show that the measure contained coherent clusters and subscales. This process, very briefly, showed us that the items fell into specific groups, which I'm going to describe next. And those that didn't fit, those items that didn't fit into one of those groups were eliminated. So ultimately, we got down to 33 items that comprised 6 subscales. Then for the reliability analysis, that showed us that the items within each subscale basically formed a coherent whole. They were related to each other. People who scored who scored one item in a certain way tended to score the other items in the subscale the same way. And then the validity analysis showed us that scores on the TIP scales were related to the constructs we would expect them to be related to. So for example, the subscale that focused on the advocate-survivor relationship was especially highly correlated with a measure of alliance that is often used in therapy research. So there was some outside validation that the scales measured what we had hoped. So here are the 6 TIP subscales. So each of these blocks describes a key principle of trauma-informed practice. The first 4 subscales, that's environment of agency and mutual respect, access to information on trauma, opportunities for connection, and emphasis on strengths. Those comprise the main TIP scale, and they consist of 20 items. Then the last 2, cultural responsiveness and inclusivity and support for parenting, have to be considered separate subscales because we have a slightly different set of response choices for them, and I'll explain that in a few minutes. So altogether, 6 subscales. So next, I'm going to just review each of these in just a tiny bit more detail, and then I'll be turning it over to Chris. So the first subscale, environment of agency and mutual respect, is composed of 9 items that assess the quality of interactions between staff and survivors, especially the extent to which staff foregrounds survivors' choice and control. So a sample item here, as you can see, in this program, I can share things about my life on my own terms and at my own pace. Remember that, like the rest of the TIP, this is from the perspective of the client or the survivor or the participant, so it may or may not reflect staff intentions. And also note that the response options for this item and all others on the main TIP scales ranges from not at all true to very true. So that's the first one. The second scale is access to information on trauma is composed of 5 items that assess the extent to which staff provide information on how people experience and cope with trauma and its aftermath. So each item focuses on a particular aspect of trauma and coping. Here you can see the sample item. I am learning more about how to handle unexpected reminders of the abuse and difficulties I have endured. The third scale, opportunities for connection, is comprised of 3 items that assess the extent to which the program offers opportunities for survivors to build relationships. Sample item, I have opportunities to help other survivors of abuse in this program. The fourth, emphasis on strengths, is comprised of 3 items that assess the extent to which staff recognize and support survivors' strengths. Sample item, the strengths I bring to my relationships with my children, my family, or others are recognized in this program. So the cultural responsiveness and inclusivity subscale is comprised of 8 items that assess the extent to which staff understand and respect various aspects of participants' identity, including culture, religion, sexual orientation, socioeconomic status, gender expression, and immigration status. Each item focuses on a different dimension of identity, and here you can see the sample items. Staff understand the challenges faced by people who are immigrants. Unlike for the other scales, participants on this one have the option to answer that they don't know the answer to the item, and this is based on feedback we got from pilot testing. So since the response options are different here, the scale had to be separate from the main tip because you couldn't combine the response options together to create one score. So that is now its own subscale. And then the last scale, support for parenting, is composed of 5 items that assess the degree to which the program helps survivors strengthen their relationships with their children. Obviously, this scale is relevant only to survivors taking care of children, so again, it had to be separate, and it also includes an I don't know response. Sample items, staff help me explore how children's relationships can be affected by witnessing or experiencing abuse and other life difficulties. So that gives you a sense of the history of how we developed the measure and just an overview of what we're actually measuring. And I'm now going to turn it over to Chris to describe more about the measure and how you all can use it. So that should work.
Okay. Thank you, Lisa, very much, and welcome everyone to this webinar. As Lisa mentioned at the beginning, we really want this webinar to cover for you why and how the tip scales were developed, but now I'll be talking about how you can actually use the scales as easily as possible before turning it over to Carol and Eleanor to talk about how it can be useful in practice. So a lot of times these scales are out there, surveys are out there, and programs don't really have the tools or information on how to actually use them. And we're very aware that you all are overworked, underpaid, don't have a lot of time to make this your full-time job. So we created this guide that is free for you, and I'm going to pull it up just so that you can see it here. And this is available. You'll see later we have a slide that says it's available on the National Center on Domestic Violence, Trauma, and Mental Health. It's available on MSU's Research Consortium on Gender-Based Violence website. It's going to be available on the DV Evidence Project website. We really want this to be widely available for you, and it's free. You can download it. You can copy it. Whatever is useful for you. I'm just running through real quickly here just so that you can see how it's set up. We have an English version and a Spanish version. Okay, so it involves a lot of information. I'm going to talk about just a few things in the interest of time today. So while the manual itself, the guide, gives you an overview of the development, so it would cover everything Lisa just covered in case you need that information to share it with others. But it also then talks about how you use the survey. When do you use it? How often do you use it? With whom do you use it? How do you figure out with staff to have a plan on when you'll collect data from the surveys, how you'll use the information, what you'll then do to improve services if necessary. We have a section just on how do you even invite participants to complete the surveys. And then it tells you a section on scoring. the tip, so there's a lot of different ways that you can use this information. You could just look at it item by item, or you could actually look at scale scores. And a lot of people don't know how to do that, so we came up with sections on here that go through that, hopefully in very easy language for you. We did have a number of advocates and service providers go through the guide with us and give us feedback. And then at the end in the appendices is the actual survey that we've been talking about, as well as a key of how to understand the responses. And again, the tool in here, even in the English version, there's a tool in both English and Spanish. And in the Spanish version of the manual, the appendices are also in English and Spanish. Okay, so I'm just going to talk today about what's highlighted here on how would you actually administer this in your program, assuming that you have no extra money or time to do this. So first of all, we're not going to tell you this is the one and only way to use the tip. What we do in the manual is describe, here are things to think about. Because some of you are very large organizations, some are small, some are urban, some are rural, you have a lot of staff, you may have few staff, you may be providing more short-term services, long-term services. So we really can't say this is the one way for everybody to do it. Instead, we talk about designate a particular time that makes sense for your organization, depending on how many clients, survivors you may see in a particular amount of time. So you might say, okay, for the next 2 months, we're going to survey everybody in shelter because we'll have enough people come through that we'll get good information. And then maybe we'll stop surveying people in shelter, and for the next 3 months, we'll survey people who are in our support groups. And then maybe we'll survey people who are getting protection orders or in counseling. So you want to just be able to ease this in. This is not something we suggest you use every single day with every single client, 365 days of the year. It's not necessary, and you probably don't have the staffing and time to do that. So what we want you to think about is to choose a time frame that's long enough to hear from enough clients about what your organization is doing, but short enough that it's not going to be a problem for your staff, that you're like still collecting data on the tip. Okay, so you want to be cognizant of that with staff. Is this a long enough time frame, but not too long? And so how many people do you want to hear from? What's a reasonable sample of people? We have here, you might decide that 40 people would give you enough that you could get a sense that we really now have a sense of what's going on in the organization. Generally, 5, 10 people is too small, but if you could hear from about 40 or 50 people, sometimes maybe even 20 or 30 if you have a smaller organization, that would probably be enough to give you a sense that this is really accurately reflecting what people who use our services think about our services. And then what some people are doing is you would complete the survey, you would hand out the survey for a brief period of time, and then look at what you might want to change in your organization, make those changes, and then survey people again. And so you can actually see if the changes you're making are going to, are really being reflected in your services. Okay. So one note on sampling, you'll see here at the bottom of this screen, is it's important when you are surveying clients that you're trying to make sure you're inviting all clients during that time frame to participate. Okay, so not just the people who are happy with your services, not just the people who are really unhappy with your services, but really everybody. So then you know that you really are getting to hear from a representative sample of the folks who are using your services. And all of this is explained in more detail in the manual. What we want to do today is just make sure that you're aware of what's in the toolkit so that you can decide whether this makes sense for your organization to use. Okay, there's also a protocol in here that you can use. It's a one-page, it goes into more detail than you're going to see here, that you can print out, share with staff, One of the things I hear from people all the time is that it's difficult to get staff buy-in when you're evaluating your program, whether you're doing general outcome evaluation, whether you're doing a specific type of evaluation. It's just hard to get staff buy-in. When I do workshops for people, that's the number one thing, the number one complaint I get is how do we get staff involved? And the main way to get staff involved is to actually involve them right from the beginning of the process. And a lot of organizations forget to do this. They just tell staff, here are the outcome surveys, you need to collect it, you need to make sure this happens, and then staff don't ever find out what did we hear, what's on the survey, what are we doing about it. So when you think about that, it's not surprising, really, that staff would not be engaged, that staff feel like this isn't important to my work, I really want to spend more time working with families and not collecting more and more paperwork. So if you involve them, meet with them, develop a plan with them, show them the survey, talk to them about how it would be helpful to have this information for the program, that this is really to figure out what the program is doing especially well and where they could make changes. Have them figure out, how often should we give out this survey? What's going to be the best way to invite people to participate? Where would we have the surveys? How long after somebody starts using our services would they complete a survey? I sometimes, when I've done outcome evaluation workshops with programs, have them say, well, to make it the easiest for us, we give out the outcome surveys when people come into the program. Now, that doesn't make sense for outcome surveys, and that wouldn't make sense for the TIP, because when someone enters your program, they haven't received the services yet. So you'll want to talk with staff. How long do we think somebody needs to be in this program receiving our services before they could answer these questions? So if it's support group members, how many support groups do we think somebody should have attended before it makes sense to ask them to complete this type of a survey? If they're getting legal advocacy, how long would we have to have worked with them? And that's really something for you to decide based on your program, but we just are giving you guidelines on that. If you involve staff, if you involve the staff who are going to be collecting the data in every aspect of this, that's how you get buy-in, and that's how you're going to get more and more surveys back and actually find the findings useful. So with staff, figure out where are we going to put the surveys when they're completed. A lot of programs now have some kind of locked box that they can put surveys into, sometimes an old rural mailbox with a lock on it and a slit in the top. You can get these at office supply stores. It might just be envelopes that people can seal if you're a smaller program. Again, it's something that if you involve the staff, you'll come up with something that works best for your program. Again, with staff, check in frequently about how it's going. How many surveys are you getting back compared to how many survivors are in your program? What do you need to change? Sometimes you try something, you realize you made some mistakes, it's not working, you try something else. That's perfectly fine. We try to just give you guidelines, but we've all made mistakes in doing this, and then we just learn from it and then modify so that you get a better return rate. And then finally, at the end of the protocol, you want to talk about how you want staff to invite clients to fill out the survey. And again, there's a whole sheet on that in the toolkit that you can copy off. I want to just go over a few basics with you. It's important that staff really think through how to invite people to complete this survey. It's brief, it doesn't take long, but still, we all know that survivors going through our programs are inundated with paperwork. There's just often so much paperwork. You don't want this to feel like yet another thing they have to do. It should never be mandatory. This should never, ever be something that clients are told you have to do this in order to get our services, or you have to do this for our funders. It should always be that you're inviting them. And so what we have found is that if you start right off telling people we're always trying to improve our services, we really would appreciate you taking a few minutes to let us know what's going well and what needs to be improved. It's only going to take 5 to 10 minutes. It's voluntary. You don't have to do it. If this time doesn't work, maybe another time would. And then there's a whole section in the form on how you can explain and emphasize confidentiality, which is really important. It's important that you make sure people have a private place to fill out the survey, that you give them like a black or a blue pen. If you give somebody a pink or a purple or a green pen, they're going to feel like you're going to know who said what. Make sure that they have a quiet place to participate. Tell them that the surveys go into this locked box or locked envelope or wherever the survey goes. And especially if you're a small program, a small rural program that maybe you don't have many clients at one time, you may want to tell people, we only open that box every month. Okay? So let them know, this is private, this is confidential. We don't want to know who said what. Don't put your name on the form. Now, more often than not, you're going to get a lot of clients saying, oh, I'm perfectly happy putting my name on this form. I love you. I want you to know how great you are, so it's perfectly fine. But in that case, you still want to say, that's fine, it's up to you, but we really, really do want to hear from everybody ways that we can improve. None of us is perfect, and so I'm happy to hear that things are going well for you here, but we also really do want you to feel free to say the things that we could improve on. Again, all of this is in the toolkit in more detail. Other things that are in the toolkit that we're not going to go over today is thorough instructions on scoring these subscales in case you want that. So let me explain that for a second. So Lisa mentioned there's these 6 subscales. You may give the whole survey, which again is not very long, 5 to 10 minutes, give the survey out, but you may want to look at your responses by the subscales. And if you want to do that, we explain how to do that in the toolkit. You may find, for example, that you're getting really, really positive responses back about how strengths-based your program is. And that's great information. That's great information to make sure that all of the staff are aware of. Because we all know nobody does this work for the high pay, the great benefits, the wonderful retirement. Okay? People do it because they want to know they're making a difference and because they really care. So to get this feedback back that our clients really do feel like you're paying attention to their strengths, that's wonderful. But let's say that you also find on the subscale about access to information about trauma that maybe the responses are more variable, that maybe while your staff is doing a great job on the strengths-based, in a number of other areas, being inclusive, culturally responsive, maybe they're not really doing much about directly talking about trauma, trauma triggers, and how people can cope when they're disturbed by the trauma. So for example, that item that Lisa mentioned, I'm learning more about how to handle unexpected reminders of the abuse. Now, we intentionally did not use the word trigger, trauma triggers, because we often talk about trauma triggers, but when we talked with experts and survivors and advocates and tested this out, that's not language that a lot of people in everyday, day-to-day world use. And so we're using language that we know is about trauma triggers, but we're using language like handling unexpected reminders. If you find that people are not answering positively to that question, that's something that you can go, great, this is something we need to work on with staff. Why aren't we doing that? What could we do more? Do we need a training on it? Do we need protocols on it? Who could be doing this? How could we be doing it? So there's lots of different ways that you can use the information in here to see what's going well, but also what to improve on. So then in the appendices, again, you've got the English version and the Spanish version of the entire survey that you can simply download and use. It also has it by subscales. You may decide just to use 1 or 2 of the subscales and not the whole survey. Again, we want this to just be what's useful to you. We encourage you to be flexible with it. This is really all about helping you make sure that you're providing the services that you're hoping to provide. As we mentioned, the toolkits are available on a number of websites, including ACDVTI's website. You are welcome to copy it. You're welcome to distribute it. This is all free of charge. We just want this to be useful to you. You'll see our contact information here for Lisa, myself, and Josie Serrata from Casa de Esperanza. We really want to hear from you. If there are things that you're finding are difficult to understand, if you think we've left something out that would be useful to you, please let us know. This is a toolkit that we can modify over time, update, and upload very easily. Similarly, if you're collecting data and you're getting interesting findings, we would love to hear about that. We'd love to hear about what's working for you, what isn't. If you even want to share any data, you know, we haven't really thought about this too much, but there may be a way down the road that we could be combining data sources. Okay? Again, there's lots of different ways that this could be helpful, and I'm sure some ways that we haven't even thought of, and so we'd really love to hear from you. We just really want this to be useful to you. So that's the information on why we created this, how we created it, and where you can find the information, and we're happy to answer questions about all that. But before we do that, I want to turn it over to Carol Warshaw and Eleanor Lyon, who are going to talk more about how this can be useful in practice and why it's important to look at trauma-informed principles in practice.
Thanks, Chris and Lisa. This is really a wonderful presentation of the tip scale. It's really a truly fabulous contribution to all of our work, so we're really thrilled about this. Eleanor and I are going to talk a little bit about some of the things that we're doing at ACDVTI to support trauma-informed practice and to help create trauma-informed organizations and systems. And to provide some additional context for using the tip scale as part of a broader array of tools and supports for doing trauma-informed domestic violence and sexual assault work. So as many of you are aware, the role of the National Center on Domestic Violence, Trauma, and Mental Health has been partly to move the field forward in addressing the unmet trauma, mental health, and substance abuse-related needs of survivors and their children through our capacity building research and policy work. And so part of that is really working at the system, coalition, and program level to do that both within the DV field and many of the systems that survivors interact with. And as part of that work, we've been partnering with many of you in the culturally specific resource centers to develop responses that are culturally relevant and address really the range of issues that survivors face, both in trying to free their lives from violence, heal from its traumatic effects, and really transform the conditions that are creating the trauma in the first place. And the big piece of our work over the last 4 years has really been to try to help build an evidence base for trauma-informed domestic violence work. As many of you know, there really isn't much of an evidence base for trauma-informed work, because a lot of it is about how we relate to each other, how the environments we create. And so it's part of why we were so excited about partnering with Chris and Lisa and Josie and Julia to develop the tip scale, because it concretizes a lot of the things that are so important both to our advocacy work and to trauma-informed work in general. So part of how we've been doing that, when we first started, there was a lot of resistance to thinking about anything related to mental health or substance abuse or trauma, for good reasons, because women's experiences have been pathologized both by the people who abuse them and by the systems that they sought help and redress from. So part of what we've done is work to create a framework that we call accessible, culturally relevant, DV and trauma-informed social justice framework, and I'll talk about that more in a minute. And the second big piece of our work is really capacity building, and some of that's been identifying models and looking at where the models that emerged from it's early trauma-informed work, which came from the mental health field, and kind of adapt that to a more culturally relevant DV and social justice approach. and then to support implementation. And part of how we've been doing that is by developing tools and curriculum. We have a core trauma-informed services and organizations curriculum, a capacity building training we do every year with coalitions, and a community of practice that comes from that, and other community practices with states that we've been working with, and a series of multi-site initiatives, which involves more intensive work at the state level, as well as ongoing training in TA in a variety of capacities. So there's a lot of that material is available on our website, and so the TIP has been a wonderful tool to support as you're engaging in doing this work, how you can measure its effectiveness from the perspective of survivors. And Eleanor will talk in a few minutes more about the other array of assessment tools and evaluation tools that we've developed and are in the process of developing. So just this is thinking about a framework, one of the things that's been so critical in bringing trauma-informed perspective and approach to the DV field is really how do we hold together both a practice and social justice framework. So part of what we're looking at in being trauma-informed is making sure our services are responsive to the survivors and experiencing the traumatic effects of domestic violence at many, many levels, but also when we bring in a DV lens, recognizing that survivors are experiencing ongoing coercive control and that their partners may be actively doing things to undermine their sanity and sobriety and controlling their access to treatment and resources and support. So we're holding all of that in thinking about trauma. It's not just the effects, but it's the ongoing social realities. Similarly, when we're thinking about the multiple types of trauma that people experience in their lives, we're not just talking about individual trauma, but collective trauma, forms of trauma as well. So not just the legacies of colonization and oppression, but from our advocacy perspective, part of what we bring to this discourse is also looking at the policies that perpetuate structural violence and discrimination. So we don't have to lose our activist perspective in adopting a trauma-informed approach. When we start doing this work, people would say, why do we even need this? Isn't this just good advocacy? But what we're really talking about is a layer of understanding that when we don't understand, it gets in the way of our being able to do the good advocacy that we all aspire to do and do most of the time. So one of the things is thinking about once we understand the effects of trauma and domestic violence, then developing a culturally resonant DV and trauma-informed approach becomes the logical next step. And I think that the TIP beautifully captures the domains, many of the domains and ways in which we're affected by trauma. So, and I think makes real the thing that sorry, I'm thinking faster than I'm able to talk. Makes real that in a way that talks about the effects of trauma in ways that reflect the real experiences of survivors, which is really critical. So the kinds of things, the trauma reminders, it allows us to talk to survivors about are we helping people to understand how that works, and what are the things that are helpful to people as they try to negotiate not only being in a shelter, but the legal system and all the things that face them in their lives as they move forward. The affect dysregulation or difficulty managing emotions, and how does that affect us, and how does that play out in shelter or DV or sexual assault program settings, and what are the things we're doing to counteract, to help survivors to understand the effects of trauma and the tools and resources they can use to make choices for themselves about how they want to be with that. The interpersonal relationships that may get disrupted because trust has been betrayed, and making it very hard to reach out for help or to engage with us as advocates who are trying to be helpful, and understanding our own responses to that is part of what gets in the way. So when we're hearing from survivors that we're being responsive and respectful and offering choice and dignity and responding in the ways that we want to respond, then we also have to be aware of our own responses and the things that actually allow us to do that, or the things that may be getting in the way. So when we think about what it means to do this work, we're actually talking about counteracting the experience of abuse. So if part of what it means to be abused is experiencing the kind of violation and dehumanization and objectification that part of everything we do, part of what it means to be trauma-informed is the antithesis of that. So that's where all of the scales of the tips that talk about dignity and respect and choice are so critical for us to be able to capture. We're also talking about mitigating and transforming the effects, and that's where the supporting healing and resilience and well-being and providing information and providing, helping survivors to support their coping skills are so critical to a trauma-informed approach, and then transforming the conditions that produce it. So our ACDVTI tool, which is a companion tool for the TIP, is really an organizational self-assessment tool that allows organizations to take the time and create a process and a kind of a readiness process to think through, if we want to become trauma-informed, what's it going to take, how are we going to be inclusive, how are we going to involve all of our staff, not just the people providing direct services, and think through what that means for our agency or organization or system. And so it's organized more around our workflow and what it's like to walk into our agency. So the practice domains that really are where the TIP focus is on what's our environment like, what's the physical environment, what's the sensory environment, and what's the relational environment, what are the ways, how do people feel interacting with us and being in our service setting, what's our intake and assessment process like, how respectful is it, what choices do people have, and what kind of information do we provide that make it possible for people to engage in our services. And again, similarly, are programs and services flexible? Are they responsive? And are they culturally resonant? And finally, what kind of collaborations and partnerships do we have with organizations in our community so that the services that we can't provide in-house, we ensure that people have access to services that are also DV, culture, and trauma-informed. But what we know is that the organizational domains that actually support our ability to create trauma-informed services or offer trauma-informed practice are really critical. And part of what that means is, what's the organizational culture that we offer for staff? Is it a culture in which everyone feels valued, where empathy is nurtured, where hierarchy is limited, where tensions are addressed openly, there are no hidden agendas, and there's a collective sense of purpose? So that's, in a lot of ways, what we'd all aspire to. Many of us work in much larger systems where this may seem more like a pipe dream, but it is part of what it is to do trauma-informed work and part of what we're trying to create through all of the tools and training and resources that we have to offer. So some of the organizational domains, one is the commitment at the highest levels of the organization to support this work. A second is creating the culture, an organizational culture that I just talked about. And the third is putting the infrastructure in place that provides the resources and support to be able to do this. And part of that really is supporting not only staff training, but staff well-being, time for reflection, quiet spaces, good HR benefits, and also what we talk about is, which comes from the early childhood field, reflective supervision, that staff really have the supports to understand their own responses, not only to the trauma that many or most have experienced in their own lives, but what it feels like to be open to the experiences of the people they're working with, who they're seeing, who are coming in for services. And also to understand their own responses to people's experiences. So that's really at the heart of being able to do what's measured in the trauma-informed practice scale. And so we do a lot of work on supporting organizations on how to do reflective supervision and how to create those organizational supports. And the last feature is the feedback and evaluation. And again, the TIP scale is a critical contribution to being able to do that and to provide feedback from survivors, which is one of the essential ingredients of trauma-informed work, both at the evaluation level but also in the advisory capacity level. And having survivors involved in shaping practices is a critical piece of trauma-informed work. And the more specific other evaluation tools that we've been thinking about, Eleanor's going to talk about now.
Thank you, Carol. You can see from the list on the screen here that we've been busy. The National Center has been working on building an evidence base for doing trauma-informed work in the in domestic violence programs and in sexual assault programs, it should be applicable as well. So this is trying to figure out in a variety of ways what we're doing, and then to focus on outcomes. What difference does it make to be doing that? So some of the things that we have done and that have helped to inform and move forward the work across the country, we conducted a needs assessment with domestic violence coalitions, which 47 completed, and that looked at things like the support they provide to programs, the internal supports for their own staff around trauma issues, culturally specific organizations and services that they're involved with, collaborative and policy-related work, challenges they're facing, and the training and TA they've received and what they need. A second one is the domestic violence programs, what we're calling here baseline surveys, but in most states where they've been administered or they've been used, they will be re-administered, so we'll be able to look at change in practice. So we provided the feedback back to programs, and they are working on issues that they choose to focus on. So we've worked with 11 states most recently and have provided versions to 9 other states early on, and there have been hundreds of programs that have been involved. There's one state that also administered the member program survey to their victim witness program, so it's moved beyond domestic violence-focused programs. And this survey looks at their program's policies, procedures, and rules, the service process, trauma-related practice responses to survivors, the program's accessibility, culturally specific and linguistically appropriate services, their staff training and support, challenges to meeting the trauma-related needs of survivors, and the community resources and collaborations they're involved with. So that's the baseline surveys. Carol has already talked about the ACDVTI assessment tool. One of the things that we're particularly excited about and have been working on for quite some time is the development of trauma-informed outcome measures. So the coalition's needs assessment and the baseline surveys were all completed by staff. These would be completed as designed for the TIP. This would be outcome measures, the what difference does it make kinds of measures that survivors would be completing. And so we've conducted focus groups with advocates and survivors, advocates asking them about trauma-related practice programs and what their perceptions of outcomes for survivors have been. And so we've done 5 with staff and 7 with survivors, asking about the services that they've received and the changes that they have experienced and what has been most important to them. 4 of those have been in culturally specific programs and in languages other than English, 3 in Spanish and 1 in Korean, have been in English. So we are pulling all of that information from focus groups and looking at other literature as well, and are in the final stages of our pilot outcome measures, which we will be pilot testing during the summer. So we're extremely excited about that. Other things that have, another set of surveys that have helped to inform some of the work are the mental health and substance use coercion surveys, one on each topic that we've conducted with the national hotline. And while they're not really building an evidence base for the work, they have to our understanding of the different types, different manifestations, different extents of trauma, and how prevalent these forms of mental health coercion and substance use coercion are. We got over 2,500 responses to this one and over 3,000 to the substance abuse one. We've also conducted research provided research briefs and literature reviews. Those are on the center's website, and they cover a range of topics, trauma-specific treatment in the context of domestic violence, interpersonal violence and substance abuse, violence and prenatal postpartum depression. We have lists of suggested readings on to wellness and healing, and a variety of research summaries. For example, one on domestic violence, trauma-related mental health conditions, and chronic illnesses. So we've done a variety of things to help build the evidence base. All of the tools, in other words, the TIP, the needs assessment, the baseline surveys, and the trauma-informed outcome measures will together comprise the ACDVTI toolkit, which will be ready as a complete toolkit in the course of the next year. So, back to Carol.
Yes. So let me just think if there was something else here. I think part of what we're trying to do is create a whole toolkit of tools that programs and coalitions can use for evaluation that include the baseline surveys, that are program level and advocate level, a self-assessment tool, the ACDVTI, that allows you to engage in a process of creating trauma-informed services, the TIP that allows you to measure whether the extent to which you're providing trauma-informed services with guidance for going back and then being able to think about what else is needed and what are the gaps, and the trauma-informed outcome measures that will allow us to look at what kind of outcomes we're actually being able to create for survivors. And, as part of building an evidence base for the really important work that we all do is going to make a big difference over the next couple of years. So, and I just wanted to end before we go to questions, and really, I think, questions that you'll have for Chris and Lisa about how to practically use this wonderful new tool, is that really being trauma-informed means embodying in our own practices and institutions the world we want to create, which is a tall order, but it's really something that I think we all feel and all need to be doing together. So I'm going to turn it over to questions. There's some resources that you'll get there. You can go to our website and find them, including the TIP. And here's some Eleanor and my contact information, and here's really all of us together. So, questions?
So this is Jen. Two of the questions that came up earlier was, one, could the TIP scales be used in a sexual assault program, and would there be any additional considerations? And the second question was, are scales or some other measures being developed for children impacted by DV-related trauma?
Well, this is Chris. I can take that, and then we'll see if Lisa has anything to add. When we created this, it really was with the idea of looking at trauma-informed practice within a lot of different human service programs. So we tested it in domestic violence. We really wanted it to focus on domestic violence. But it turns out that a lot of the items, it looks like, really would fit for a lot of different human service organizations. So I think it would be a wonderful idea if somebody with more sexual assault expertise were to look through this and get a sense of what they think would relate and what's missing. Maybe there's a whole nother subscale, maybe there are some different items, maybe there's nothing to add. I think it would be wonderful to check that out with people who have a lot of expertise in that area. And then with the children, boy, that's a whole nother area. I'd love to see something for children, but I think that would have to be a completely different toolkit, and of course you'd have to have different ones for different developmental stages so that, you'd have questions asked or presented in a way that would work for younger kids differently than for older kids. So that's not really my area of expertise, but I'd love to see somebody do that. Lisa, would you add anything to that?
I guess one thing, and I completely agree with everything you said, one of the challenges in developing this measure was what to call the trauma that people have experienced, recognizing that domestic violence may be one among many different traumatic experiences, and that people call that violence different things, even if they are talking about, intimate partner violence, what we might call intimate partner violence. So that was one of the questions that we really focused on in all of our hundreds of conversations with experts and survivors and practitioners, and sort of recognizing that we needed a word in English and Spanish. And the word that rung true for the vast majority of people was the word abuse, as a sort of general catch-all that wasn't, it didn't catch, some of the experiences people have had that might be very relevant for particular communities. So we added the word "and other hardships" after the word abuse, but that was sort of the framing. Not all items have this phrase, abuse and other hardships, but the ones that particularly ask about how they cope with prior trauma tends to use that language. And that really worked when we pilot tested this with survivors. So I guess back to the question about whether this would work for sexual assault survivors, when we were asking about what kind of language is best, we were thinking of intimate partner violence in particular. That part might need to be shifted, depending on how, sexual assault survivors name their experience. But I think that the items themselves, the substance of the items, separate from that language question, I think would be applicable, and I too would be really curious to see what might be left out of from this tip, if applied to sexual assault survivors. It'd be really interesting and important to find out. And I think that the child question is super cool, but I don't think that there is such a thing yet. I don't think that there's a scale that measures children's experience in domestic violence programs. By the way, I see the words violated and exploited, also really fantastic words.
So I'm just seeing Leanna. I think Leanna asked about training and technical assistance for programs and coalitions after doing the TIP, and that's really part of what the National Center does, is provide that kind of training in TA, both at the front end and response. And we're also developing a new version, an updated version of the ACDVTI tool this summer, so hopefully that will provide more guidance on using it as well as a companion to the TIP.
Lisa, I see we have a question on what's the literacy level of the TIP scale, and I know you've put a lot of thought into that and got a lot of feedback from the organizations on literacy, so I'm going to turn that one over to you if you don't mind.
Yeah, and so I'm trying to, we have put this through software, and I think where we ended up, but I don't want to be absolutely cemented into this, but I'm pretty sure we ended up at an 8th grade level. Just because, and we had a couple of words in there that prevented it from being even a lower level that that survivors wanted us to keep in. But I'm going to say that it's around an 8th grade level.
But we did hear back from organizations, didn't we, that most of their clients were able to complete this pretty easily?
Yeah, I mean, this was pilot tested with several large and diverse groups of survivors. But then in addition to that, we got extensive feedback on the first as we began to administer it to the 350 survivors across the country. And yes, the feedback was that there were no issues with understanding the items in Spanish or English. This was after, I mean, and believe me, there had been issues with our first draft. There had been lots of issues. So this was, the final version that went through the pipeline of many people with many adjustments along the way. But the final one seemed to be pretty readily understandable to people.
And regarding the timing of giving this survey out, we're not necessarily suggesting that you would do it as its own standalone separate survey. You certainly could, but many of you are already doing outcome evaluation surveys, exit surveys, that kind of thing. And since this is only 20 questions, you could add this to a survey that you're already using if it doesn't add a lot of length. So there are a number of different ways that you could use this.
I see the question about helping board members to become more trauma-informed. And as a board member of a domestic violence organization myself, I really resonate with this question. I wonder if others have a response to that, Chris or Carol or Eleanor.
Well, I certainly agree with it. I know some state coalitions do work with boards. I know Carol's group does trainings and technical assistance, but I agree if boards don't understand the importance of being trauma-informed and don't engage in it themselves, it's hard to have that actually go through the organization.
You know, one way in which actually this measure could be very helpful for a board would be to ask them to fill it out how they imagine a survivor in the program would fill it out, just to get a sense, you know, because the very act of filling it out gives them a very, you know, quick and superficial, but nevertheless some, you know, sort of sense of what we're talking about when we talk about trauma-informed practice, and will give them also a sense perhaps of the diversity of their responses, indicating an absence of real knowledge of what's going on in their program. So that might be, you know, short of, I know that there are programs that require a certain number of hours of DV training, but and trauma-informed training on top of that, but most don't. So that would be a way to just begin a conversation.
And I'm thinking also that part of it for boards, I'm wondering about their responses to staff and to the organization and their own approach. And so having some information about what it means, what it takes to be able to do it. So if programs aren't doing it, to really understand the supports that staff need and in order to be able to do it, and the resources that they need to bring to creating an organization that can actually do trauma-informed work. So I think the tip scale accompanied by some understanding of what that means for organizations would be really helpful. Yeah.
I notice a question here on how do you use the survey with people with very low literacy or who don't speak English or Spanish, and that's a great question. We do talk about that in the toolkit, but just briefly let me say that people have been very creative about this. You can have staff or interns or volunteers verbally administer the survey, and some are doing that. You just would want to make sure that it's not somebody who has provided service to the survivor who's asking the questions, because that puts people in an awkward position. You know, you don't want to have to tell somebody to their face that you're not happy with the service that they've provided. But some programs have used, say, interns, college interns specifically for this. With technology now, it's a lot easier to actually have somebody tape record the survey in different languages if there are other languages that make sense for your organization beyond English and Spanish, and of course there are. So you can be creative because we don't want you to leave those folks out. And unfortunately, that's often what's happening in programs is people who either through literacy, language, disability, can't complete a paper and pencil survey, don't get to give their feedback. And none of us wants that to happen. So we do offer some ideas in the toolkit, and we really encourage people to share what's working for them with others. The most common that I'm hearing, though, is that use of volunteers or interns who don't provide direct service, who just come in and administer these surveys, especially when you can get those interns or volunteers who speak different languages.
Yeah, just one thing to add. It was the great Josie Serrata's innovation to include in the response options a little hourglass that is, you know, not at all true is an empty hourglass, and it goes to somewhat true, all true. I think that's the direction it goes. And that was designed specifically for people with low literacy levels, so that if someone, even if you don't have interns available, if you have someone who can translate the measure or read it, if maybe the person does speak English or Spanish but doesn't want to or doesn't feel comfortable reading it for themselves, you as a staff member can read the question to them and have them hold the survey and just circle the response option for each question. And all they need to do is look at the level of the hourglass to figure out where they are in response to the question. So ideally, you would have this be completely separate from any staff person about whom the survey is, but if you can't do that, you can at least give them the survey, you read the questions, they can circle the responses, and then they can put it in the pile with the others or in the box or in the sealed envelope or however you're doing it.
So, any more questions?
Well, if there are no questions, I just want to thank you all for taking the time to be on this webinar. I know how busy everyone is, and it was nice to have such a large number of people attending the webinar, and we hope you really will check out the toolkit and give us any feedback on it. We would really love to hear from you. This has been quite the labor of love.
Yes. Okay. If you have questions after the webinar ends, please email us and we'll respond to you. If you think of something later or you try it out. But thank you all for attending. Jen, Erin, are there any final things about the evaluation?
Yeah, absolutely. So this is Erin. Thanks so much. I want to thank Lisa, Chris, Eleanor, and Carol again for such an exceptional webinar today. Thank you to Caption Colorado for providing today's captioning, and thank you to Jen Curley for making the webinar run smoothly. Last but not least, thank you all for spending your time with the center today. Within the next week, I will send you all a follow-up email with a link of the recording of today's webinar, in addition to the slides and handouts that were referenced, all of which will be available on our website. You will also receive a certificate of attendance for your time today. At the end of the webinar, as soon as you close out the window, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, that would be greatly appreciated. Thank you again, and we hope you have a great afternoon.